I have a couple of presentations. I actually am talking about the results of the CALGB 80802 study, which is the doxorubicin plus sorafenib versus sorafenib phase 3 clinical trial for first line in hepatocellular carcinoma. And this will be at the oral presentation session for the non-colorectal GI on Monday morning. And this will be followed by the arginine deaminase ADI-PEC20 versus placebo phase 3 trial again in second line in HCC as well.
Could we talk some more about the sorafenib trial first?
The story of the sorafenib doxorubicin is really as old as sorafenib itself. Actually, from the first day when the sorafenib was launched, or rather the sorafenib study, the SHARP trial was launched versus placebo in first line, we launched a study of the doxorubicin plus sorafenib versus doxorubicin plus placebo at that time, because understandably there was no sorafenib data, and at this point in time it was the understanding at least that doxorubicin is a standard of care. This emanated from phase 1 data that showed in this combination there could be actually some potential benefit for the combination in HCC specific. Add to at least the 3, if not 4, mechanisms of action that really will enhance that combination. And as such, we embarked on that study, and this was reported also already in the Journal of the American Medical Association, or JAMA. And in an exploratory analysis where we compared the two arms, the study was not powered, it's a randomized phase 2 study, but we compared the two arms of doxorubicin plus sorafenib versus doxorubicin plus placebo, and we found a critical improvement in survival for the doxorubicin plus sorafenib arm, 13.7 months versus doxorubicin plus placebo, 6.5 months. Obviously clinically and statistically significant. Now, you can imagine what the question would be. Is this really the combination, or is it really sorafenib on its own? We really didn't know at that time. Nonetheless, the appropriate and appropriate second step will be to do the study of doxorubicin sorafenib versus sorafenib. And that's really what led to that study, which is under the umbrella of the Alliance now, which is the Alliance for Clinical Trials, or previously CALGB plus other cooperative groups, multi-cooperative group run by all the cooperative group under the umbrella of the CTEP and the NCI. That's a very important study because it's the first historical ever phase 3 trial in HCC run by the US government NCI. And so it really, why this is important, yes, it's nice historically, but also it's critical because it shows that HCC is unfortunately a disease that's abundant in the US, and another accrual to that study is very feasible and possible. So that's a very important conclusion regardless what the data shows.
When it comes to the results of sorafenib by itself or in combination, what is the best combination, the best course there?
Well, unfortunately, the data did not pan out as the data is reported at this meeting. Doxorubicin plus sorafenib did show a median survival about close to 9 months, and for the sorafenib close to 10 months, which is the classic what we see with sorafenib alone anyway. There was no clinical or statistical significance. So, in addition to that, we found that, of course, the added toxicity from the doxorubicin was noticeable. We're adding a chemotherapeutic agent. And as such, I would say this is not a combination that we would recommend for further use in the first-line setting. And the only piece missing still in our part of the puzzle is a lot of correlative work that we're hoping will come out and maybe we'll learn more from.
And then moving on to the ADI trial, could you tell us more about that?
So the ADI is really a different story altogether, and it's a fascinating story. So arginine deamination is actually a mainstay and a powerhouse for the treatment of leukemia, as we know. Our bodies depend on arginine to survive, and our cells need arginine as an essential amino acid. And of course, you can deplete arginine and kind of kill the cells, but the body is smarter than that. If anything, when you deplete the arginine through ADI-PEC20, it turned it into citrulline. And citrulline abundance in the cell will turn citrulline back into arginine through two enzymes. One of them is called arginine-succinate synthetase, or ASS, and the arginine-succinate lyase, ASL. And the beauty of that experiment is not the drug itself, because the depletion of the arginine is one story, but along with it, we have found that actually primary liver cancer, or HCC, lacks ASS. And as such, your ability after you deplete the arginine to replete it through the citrulline is not there. And as such, the cells die. With this all said, A couple, or at least 3 phase 2 clinical trials have been reported in the literature that showed an improvement in outcome in the second-line setting as well as in the first-line setting for patients who are receiving ADI-PEC20, which is a pegylated form of arginine deamination. And as such, a phase 3 trial was a totally appropriate next step. So a randomized phase 3 trial in the second-line setting, randomizing patients to ADI-PEC20 versus placebo, and this is the data we're reporting. Unfortunately, again, this data did not pan out. The median survival was really across the 2 arms, very similar, like not different at all. But we are showing at the meeting a fascinating piece of data where if you show the arginine depletion that will last more than 7 weeks, corrected for the number of treatments. Of course, we don't want to say like we treated more, that's why people do better. But if you correct for the number of treatments and you correct for the baseline arginine level and you show that the depletion went before 7 weeks, then the 2 curves will open up like magic. And there is a clear improvement in survival for that subpopulation. The other thing we learned along the way also, that our population in that study is very heavy on sorafenib pretreatment. And in other words, they are all either received sorafenib and they failed on it, or they received sorafenib and did not tolerate it, close to about 80%. We discovered that actually if you pretreat with sorafenib in cell lines, and this data we did not know at that time, if you pretreat with sorafenib, cell lines with HCC cell lines, ASS goes up. And as such, we already sadly created for ourselves a phenomenon of resistance without knowing it. And interestingly, again, we have the 20% population, which is very small, but if you look at that population, no statistical significance, and this is a look that we did despite being part of the subgroup analyses that were planned and the stratification that's planned. Nonetheless, we see that the 2 curves again open up. So I think, again, this study is still negative in regard to proving that ADI-PEC20 does not work in the second-line setting at the dose of 80 milligram per meter square, because we have some question about the dosing as well. However, it opens the question in regard to future development from the perspective of how much of arginine depletion you want. Number 2 is how you mitigate the resistance to the ASS elevation. And number 3, dosing, and probably also some form of a new generation of ADI-PEC20, because also one thing we found is that because it's pegylated, the body will develop antibodies, and is something to mitigate as well. So a lot of learning that hopefully will follow on in this world of metabolomics.